Hello, my name is Arnie Rosen, and I'm talking today on managing technology for best outcomes and productivity. But before I start, I would like to thank Dental XP for giving me the opportunity to participate in this webinar, and I'd also like to thank Dentsply for supporting this program. So to understand the management of technology and how to leverage it for best outcomes and productivity, there's some concepts that are important to understand. One will be the concept of opportunity cost. Another will be something called a value chain. Another is goals of technology. And finally, we'll put these concepts together and show clinical examples that demonstrate clearly these concepts and demonstrate how we can leverage technology to be more productive and at the same time give our patients the best outcome. So concept of cost. There are all kinds of costs. There are fixed costs, there's variable cost, and then there's something called opportunity cost. Now, opportunity cost basically means that your time is a resource that is not free. It has an opportunity cost, which is the measure of value it could generate if put to productive use. You know, if tomorrow morning I go to my practice and the chair is empty, my lab work wasn't there, patient wasn't confirmed, for a number of reasons, I've lost the opportunity to generate income. And that could be in many different ways. So for instance, often a dentist will say, well, something failed, I'll redo it, it's only my time. Well, your time is all you have to generate income. And by the way, your patients also have value to their time and don't want to spend all of it traveling back and forth to your office. So they want the opportunity to have good service, to have good outcomes. And opportunity cost can be defined in many different ways. So for instance, let's say you decide that so you don't lose income for redoing a particular prosthesis, you'll do it after hours. Well, maybe you'll lose the opportunity to go to a sporting event for one of your children. So there's opportunity cost. And one example I wanted to show you, one example that was one of the best examples of opportunity cost that I've seen. There's a patient who comes to my office and she complains that every day since she got this prosthesis and these implants, she's in pain. Well, something happened that did not provide her the opportunity for best outcomes, and certainly it was not very productive for the dentist who relines this patient's tissue conditioner every month. So you can see with diverse implants and that the optimal way for an attachment to work is to be parallel and to match the path of insertion of the prosthesis. In this case, that's impossible. So we went and said, well, let's start at the very beginning, and went back and took a CT scan. And you can see what we found. We found a couple of things looking at this. Number one, the patient's mental nerve is right on the crest of the ridge, so every time the patient bit down or closed, she would experience pain because of the nerve. And if you look on the right-hand screen, you can see that when we took measurements, there was no opportunity to put additional implants except one between the two front implants. So we've lost the opportunity to provide the best potential service for this patient, and the patient lost that opportunity. So there was a tremendous cost both in productivity, doing all of these relines, patient coming for all of these relines, lost the opportunity for best outcomes and certainly was not productive. So this is one example. This is another example of something that I would call a rescue that I saw in LMT. And it's an elegant restoration with three perfectly parallel locator abutments. But what I see here are two implants that were improperly placed. So I'm going to have, because they're in labial version, I'm going to have a denture which is over-contoured on the labial. In addition, the expectation was two implants, two locator abutments, and this elegant restoration or bar prosthesis added an additional $1,800 on the cost of the work. So we didn't have the best outcomes and certainly were not as productive as we would have liked to have been. So the next concept that I'd like to talk about before we talk about technology is something called the value chain. Value chain is something that one of the gurus of Harvard Business School came up with this discussion on competitive advantage, creating and sustaining superior performance, and it was particularly suited for a global economy. This was back in 1985. And basically what this concept is that from the time that a patient comes to your office, and this goes for any type of business, from the time the patient presents, there's a chain of events that occur from the time they come and they see your front desk, that you do diagnosis and treatment plan, that you execute surgery, prosthetics, dental lab interaction, and follow up with this patient before they have some end result. And often we spend our time looking at trees and forget the woods. This value chain, if you can keep this in your mind, will help you to understand that to leverage technology, that we need to really leverage all of these aspects of treatment to provide the best outcomes. And if we provide the best outcomes, we will be the most productive we can be. There are numerous business models that demonstrate this clearly. And incorporated into this value chain are a number of different components: technology, products, suppliers, communication. We could go and look in every one of these boxes and spend all day discussing them, and we could quantify, look at it from a quantitative and a qualitative point of view, and see how that impacts both our productivity and the quality of care that we provide our patients. So I look at this value chain, and much of the technology that we do in our office is provided by suppliers. So we're looking at practice development from suppliers, digital planning, regenerative materials, implants, restorations. This is specific to implant dentistry. But this value chain applies to all aspects of dentistry, everything that we do. And if there's a message that I would hope that you'll get from what I'm going to discuss, it's that effectiveness depends on the ability to manage the linkages between all activities in the value chain. What that means is there isn't one specific thing in technology, like an intraoral scanner, for instance. You could say, wow, that's great. I want to buy one of those. It's impactful, but does it impact the value chain, and does it create some impact on workflow and provide some benefits that link other aspects of the value chain? So I would implore you to take a close look at the way that works. The linkages are about seamless cooperation and information flow. They lower cost and improve performance, and I think I'll be able to demonstrate that clearly. So now let's talk briefly about the goals of technology. I view the goals of technology to requirements for me is to improve planning, design, and manufacturing standards, to improve workflow and outcomes. That drives this value chain. Increase productivity and reduce cost. It's scalable, so it's not something that I could do on one tooth. It's something that impacts the oral cavity from a single tooth to the edentulous patient. It's retrievable. So one of the huge benefits of digital dentistry now is that you can retrieve something and not have to start from the very beginning again. So that retrievability gives you the ability to save. So 5 years from today, everything we do has a useful timeline to it. So 5 years from today, something needs to be redone. You can retrieve information that you have saved, and you can use this to help to redo a prosthesis, for instance. And it helps to manage risk, and that will be very clear. So probably the best example I could think of in terms of leveraging technology, and one of the first that really was impactful to us, was the concept of the custom abutment. So this custom abutment, what you're looking at, is what I would consider to be the gold standard. Now, it doesn't look too pretty. It's a custom abutment that was a UCLA abutment done by an excellent technician, but what it shows is that the manufacturing standards here is very variable. Now, I'm sure there are some technicians that could make this look perfect, but the question is, on a regular basis, can they make it this perfect? And so this is something where there's been digital design, digital manufacturing, to come up with a product that exceeds exceeds the ability that an individual can do on a regular basis with the UCLA abutment. So let's look at some of the aspects of this on an individual basis. Well, first, the labor of doing this abutment was approximately 2 hours, and that included wax-ups, it included investment, casting, finishing. All of these things are very important. Very design technique sensitive, so it was very, very dependent on the quality of the technician, and it became more and more design technique sensitive if there are multiple units rather than an individual unit. And it's very limited in design change. You have what you get. You get an abutment and you're not happy with it, and you have a final restoration with it. Well, the ability to change design is very limiting. And the manufacturing is very technique sensitive. There's no recovery. You lose the abutment, you start over again. Something isn't right, you start over again. So there's no recovery. And the cost of that was anywhere from $500 to $800, which was a tremendous barrier, at least in our practice, to be able to deliver to most patients this type of technology. So now let's take a look. This happens to be a gold hue, patient-specific abutment. And the labor of this is about 30 minutes. And that 30 minutes basically is a technician validating, approving a design, a digital design, changing the digital design if necessary, and handling the abutment. There's standardization of design. So this abutment was designed from something called a virtual abutment design. So it takes a perfect tooth, preps it in the manner that we would normally in the mouth, and then gives a standardized design that the technician can then approve or alter as needed. And standardized manufacturing. If 5 years from today I need another abutment, I'll get the exact same abutment back. And easy recovery. Things get lost in the mail. They get lost in our office. I drop something on the floor. It seems like it always disappears. All I have to do is make a phone call and request the milling of another abutment. An easy design change. So if I have an abutment in the mouth and I have a little apical migration of soft tissue, it's easy for me to request from the laboratory for them to lower the margin digitally and generate another abutment. So I have this easy design change. And the cost is reduced significantly. The cost would now be somewhere between $300 and $450. So you can see how we've taken technology and we've improved outcomes and we've improved productivity. So once again, those goals of technology: improve planning, design, manufacturing, improve workflow and outcomes, increase productivity, reduce costs, be scalable, retrievable, and manage risk. So I view technology today that we're all faced with this chain of events that occurs. Now I'm taking this digital aspect of it and taking it and kind of focusing on this while there are other aspects of the value chain. But it comes in 3 different ways. One is that we acquire information, and that can be with a digital scanner or some kind of digitized information. We process it, we plan, and then there's manufacturing. So we're kind of in this quandary. What do you invest in? Where do you get involved with technology? How do you make use of it, optimize the use of it? And a lot of what I'm going to talk about is I'm going to talk about how you get involved with technology. So I'm going to start this conversation first by looking at a patient that is not an implant patient. And we're going to look at this patient who needs a lot of restorative dentistry and wants a better smile. So we're going to talk about how our office participated with leveraging technology in this case, and show you that much of what we do is exported. So we export technology and are dependent on laboratories and on manufacturers and suppliers. So we started with this patient, and what you're seeing is basically a value chain. And if you look at the top of this chain, where the laboratory was involved, they intermingled digital technology with analog technology. And if you look below on the clinician side, we did almost everything from a standard methodology or an analog methodology, and really depended on the laboratory and suppliers for the digital leveraging of the prosthesis and the process to provide us an outcome or a product that was desirable or acceptable to us. So we'll start at the beginning. So we made a conventional impression, a model, and then this went to the laboratory, and we did something else. We did a simulation. So we took the patient, we did a digital simulation. We were able to show the patient what we might be able to achieve and get feedback from the patient. And what is interesting about this is that we have the capability with technology to merge data sets. We can actually merge what you're looking at the bottom of the screen to help to define what the final outcome will be, and I'll demonstrate that a little bit to you later. So we had this opportunity. We digitized the laboratory now, digitizes the model, does digital planning, does digital manufacturing of the provisional, and then finishes it on a solid cast. So you can see there was much digital technology here, but we started analog, the laboratory went digital, and the laboratory brought it back to an analog state. So then we did things in the normal manner. We prepared the teeth. We did the provisional by relining it, and we took a conventional impression. Now, this could have been a digital impression, but it was taken with conventional impression materials. And then the laboratory poured it, made a model, digitized it, and once again went from a solid model to a digital, and merged the data sets of the provisional, and even merged some of the data sets from the simulation to give us a predictable outcome. And then all of the restorations were milled. So all of the restorations you're looking at are solid, monolithic crowns that had some very small cutback and staining to give them to optimize the aesthetics. So they were milled and they were remounted and finished on a solid cast. I'd like to thank Lee Kalb for the beautiful work that he did. And very interestingly here, now you might look at this and say, geez, it's not white. And one of the things that we found from the simulation we did was that the patient and the patient's husband actually said, we don't want her teeth to be white like that. We like the shapes of them, but we want them to match more her normal teeth. And so we were able to achieve this. So we went through the stage of leveraging technology to improve design and manufacturing standards. But the leveraging of the technology was by the supplier and by the laboratory. So while we are moving towards digital hardware and software in our office, which I'll talk a little bit about, most of our leveraging comes from the way that we work with the laboratory. And from this, you must understand that value seldom comes from an individual technology. Value comes from merging technologies along the value chain to improve outcomes, productivity, and the cost of care. So we'll start with digital planning. Obviously, this is something that you can't live without, and you can see a patient who presented our office and had this very unfortunate result. She had 2 implants that from surgical execution were integrated, and the surgical technique was done effectively, but it was also done with planning from a 2-dimensional image. And you can see that the unfortunate result is that the patient now has paresthesia, chronic pain, and presents to us which time we take a CBCT, and this is what we see. We currently use in our office implant, which I consider to be the gold standard for CBCT, and we've been using it for over 15 years, originally from Columbia Scientific. So we start off with this planning, and here's the opportunity to show you a little bit about how we can merge different technologies. So here's our patient presenting, has a removable partial denture. And you can see clinically from the facial and from the occlusal that there's a fair amount of labial loss of bone. And while there's adequate bone for implants, what we're able to do is to demonstrate to the patient the value of doing grafting in terms of its impact on aesthetics. So here you can see the patient where the model has been, an image of the patient has been merged with the CBCT. And here is a simulation that has been merged with the CBCT, and it helps to generate understanding on the patient's part, and it helps us to understand the clinical procedures necessary to achieve what we're planning for. And we're able to take this CBCT, plan our implant placement, and also the restorative aspect of it by seeing the restorative space. We can even put abutments on there, virtual abutments, and evaluate and actually design the final prosthesis. So this was one place where we decided, well, do we outsource CBCT or do we bring it into the office? And it was really, there's a huge investment in doing this. So we had this opportunity and had to decide, will we do this or not? So what are the factors that help us to make a decision on outsource, to buy or not buy? Well, one certainly is cost. Another is space. Do we have the space in the office? And another is human resources. Do we have the people in the office that actually can help manage this? Well, we decided the answer to all of those was yes. We have the space. We have the human resources. We can afford it, but is it something that we want to invest in? So the purchase, we figured if we purchase, we accelerate workflow. It's a patient convenience, and patients love going to one place. It reduced cost to the patient because we actually figured that we could deliver this service, charge the patient, have it as a profit center, and at a reduced cost of what the patient was, what it was costing to the patient. There was tremendous impact on the clinician convenience because we could, at a first visit, have a patient have a CBCT. We were able to engage them and get them involved right from the beginning. That was a tremendous benefit to us. It also allows us to do segmental images, which we find very important, not only initially if we're doing a single tooth or a couple of single teeth, for instance, in a cosmetic area, but what we also found is that there was a need for follow-up segmental images to see how effective a graft was. Is it ready for us to place implants? If we've grafted now, if we want guided surgery, we need something current in order to be able to plan that. So for segmental images, clinicians' convenience, it was tremendous. And having these post-grafting images we find to be really critical in providing the best outcomes for our patients. And also, there was a dramatic increase in the conversion of patients who were thinking about it to see that we had this technology and that we were able to impact our workflow had a tremendous impact. So we looked at the purchase, and the purchase price was $111,681. That was 36 monthly payments of $3,433. And we figured we had to do 17 scans to break even. Well, in fact, the actual scans per month ended up being about 20 in the first month, and that number escalated rapidly in a very short period of time. So it was something that had a huge impact on us and was a no-brainer. So we're delighted with it. It has impacted the quality of outcomes in our practice. It has made us more productive. It has made our patients happier. It has been a convenience, and it's been a profit center. So it was a wise and a good investment for us. So now let's look at this value chain. And this is an interesting, this particular patient provides a couple of interesting things. One is that you see an implant that was not terrifically planned. You can see that there is grayness in the soft tissue, but the patient presents to us with tooth number 6, the canine. It needs to be extracted. There's external resorption. So now we're going to, we've got this value chain. We're going to need a CBCT. We're going to do guided surgery. And we're going to link this to the restorative aspect of things. So we're going to shorten the timeline. We're going to leverage technology. And we're going to do this with something that is called immediate smile. So we start out, we take the CBCT in the normal manner. And then we're able to plan the implant. We're able to plan the restoration. And you can see here that we have the design of the surgical guide that we can view because we're seeing the design within the context of the CBCT software. But what we're able to do here is something that goes beyond just doing an immediate implant. You see we've done atraumatic extraction. You can see the tooth came out in pieces. Okay, and here's the surgical guide. And I'm not going to spend much time talking about this except to say that what we delivered at the time of surgery was an immediate placement of an implant, a patient-specific abutment that was manufactured from the design, and a milled provisional that was made for the patient-specific abutment. So we've been able to link different aspects of the value chain to merge them to shorten the timeline and be more productive, more effective. And we had a reasonably good result with this patient. What you're looking at is at the time of surgery in the right-hand screen. So what you see here is the patient before and after. You can see the canine is a reasonably nice finished restoration next to an implant in the position of number 7 that was not so well planned, not so well executed. So this is showing you how leveraging technology and merging technologies, which we depended on a supplier to be able to provide these services. So we exported, we internalized the CBCT, we exported technology to be able to have the surgical guide, the custom abutment, and a provisional, which could have been a final restoration. So we're going to look a little bit about at restorations at basically patient-specific abutments. So we'll move down that value chain, and now we're going to look at the patient-specific abutments. So first, clearly, there's a difference, and it's hard to justify paying more for a product that you can't retrieve, doesn't have the design characteristics and the design qualities and the manufacturing qualities of the custom abutment, which has become a well-accepted product in the marketplace now. And just to see the differences of what some companies have the capability to do, not just I have software, I can mill something for you, I can mill a custom abutment and I can do it cheaper. But there's a difference between that and working with a company that develops technologies such as you're looking here at the custom abutment from such as the patient-specific abutment from Atlantis. So this is a screw-retained restoration shortly after it's been placed, and this is pretty common now. The next evolution of this product line was something called the crown abutment. So what you're looking at is an abutment that was made to allow for the layering of porcelain on it, so it's a screw-retained restoration. It's a zirconia base. This also comes in titanium, but it's an elegant restoration, and you're looking at that first molar about 5 minutes after it has been inserted. Another example shows a beautiful emergence profile, and it shows that it has the ability to emerge like a natural tooth, so we don't have large spaces, interproximal spaces that can catch food. So it really allows for a very natural restoration, and it's retrievable. So next on this production line is something called an insertion guide. So we have a custom abutment. Now, one of the things that I consider to be an inconvenience or pain is the seating of the abutment. Well, this insertion guide, often I know that you get from the laboratory. They'll give you a little guide that they make from GC resin or some other type of resin. And here we have something that has been generated by computer. So it's planned to fit exactly. And you notice on the bottom there's a little loop, so that's to put some dental ligature on to reduce risk so that you can retrieve it if the patient starts to swallow it. So this shows you the insertion guide in its virtual form. Also that there's a manufacturing stamp on it, so it can be traced back to its manufacturing if there are any issues associated to it. And this is a clear example. Clearly, this is different from having something that's been made from Duralay or some other autopolymerizing resin in the laboratory. So it's made better, the cost is lower, and it comes manufactured with the patient-specific abutment. And here's an example. The GC resin on the right-hand screen, it was done well, but you can't compare if you take the time that it took to do that, that there is definitely, it impacted by having this insertion guide, it impacts the way that you're able to, that improved product benefited from better standards for design, better manufacturing standards. In fact, if you just take a look at this, some of the benefits are, well, here's an abutment, here's the insertion guide, and you can see that we're holding the insertion guide and the abutment is not falling out. So two things here that were a benefit. One is I can tie dental ligature around it. So particularly if I'm working in the back of the mouth, I don't have to be concerned about the patient having a problem with it. Secondly, you can see I'm holding it and the abutment isn't falling out. So this is not trivial to get standardized manufacturing that will have just the right amount of pressure that allows the abutment to be carried and not stick in the insertion guide and have just the right amount of tension to be able to hold it properly. So this is all part of design manufacturing, and here it is that we're delivering that abutment. So next, now we're expanding ourselves in this value chain. Next is something called a core file. So at the time that the abutment is being manufactured, as soon as the design is completed, something called a core file is completed. This core file goes to the laboratory, and what happens is that it is basically the core of your restoration. So the laboratory can be manufacturing the crown at the same time that Atlantis, in this case, is manufacturing the patient-specific abutment. So we're compressing time again. We're expanding over the value chain. We're showing you that a development company is different from somebody who I can design an abutment and mill it for you, and I can give it to you a lot cheaper. Well, there's value in having something that is expanded over the value chain. So let's just take a look at digital planning and how it's impacting this interesting case. A patient who is a surgical nurse, and she's been told that the only way that she can be treated for her bimaxillary protrusion is with orthognathic surgery. And she says to me that I've assisted for that, and there's no way that I'm going to have that kind of procedure. So we went through the process of making standard models, digitizing them, and going through digital planning. So we're going to be merging data sets here. We have digital planning of how we're going to retrude the teeth. We can view this with our CBCT. You can see in the upper left that we're going to put an implant in that will accommodate the new location of the teeth. And it shows that we're able to define what the potentials are for this patient from an implant standpoint. Okay, showing you on the right-hand side that there's a tremendous difference in where we're going to be placing the implants. And this is all planned digitally. So we're working in a virtual environment, and we're coming back and we're making provisionals based on this. Step one for this patient was extractions, provisional, and this provisional was milled, and we have a data set now of this provisional, and we're going to be making changes to improve this basic design. So we went ahead, placed the implants based on our CPCT planning, and then you can see here that we had patient-specific abutments made and a provisional made to be delivered at the same time. So we have three things actually. We have abutments, insertion guide, and a provisional. So we've been able to merge all of this, and you can imagine when the provisional is already made to fit the abutments, that it reduces the amount of time and our capability to deliver a good product to the patient. In fact, this provisional restoration will be a prototype of what the final restoration will be. We have it digitally. We can make changes digitally if we're not happy with any aspect of it. So we can deliver this all at one time. And here we have the insertion guide. We're placing abutments. Here we are with the insertion guide finishing the placement of the abutments. And then it's very simple that there's no relining of the provisional. The provisional goes right to place. We may have some occlusal adjustment, but it's minimal, and we've planned for what the design will be. So we leverage technology here. We could carry this to a final restoration. So we've leveraged technology in this value chain to plan digitally. But you can see here we're working on a solid model. So even here, we're intermingling analog and digital technology. So we have abutments, insertion guide, provisional. And here we are showing you just how we're moving forward with this patient. We're going to take a look at another clinical situation and demonstrate how some of the attributes of digital technology have impacted what we do. So here's a patient who many years ago had a beautiful restoration that was made on Sonata abutments. And the patient presents at this time, number one, patient seldom does he brush his teeth. Gingival tissues look horrible, and he has several fractured areas in the porcelain. And the veneering porcelain was done beautifully, but this is a patient who's very difficult, very hard on everything, and all materials have a useful life to them. So you can see we did some tissue management just to get the patient's tissue looking better. And we made an impression in the normal manner, and we did our digital planning as I had shown you before. So we had a solid model, digitized. I could have taken an implant. I could have taken an impression with an intraoral imaging system. We chose to do it in a conventional manner, in an analog manner, and it was digitized in the laboratory, and we expect that we're going to go back to a solid model. So we accepted the design and had a provisional made. And here, the provisional is in the patient's mouth, and it required no relining, and it was, a beautiful restoration. Now, this patient, I had a sense of concern since this patient seemed to break everything. I think we all have these patients. And so the patient went away and was kind of like a snowbird, and from Boston went and spent some time in Florida. And I was concerned about what would happen if the patient would break the provisional. So just before the patient was returning, the patient was a laser physicist. So he sends me this letter that says, "Dear Arnie, the upper bridge failed miserably. View from above, loose section, cracks, all my eating done here. These two fell out. So I knew the patient still had a good sense of humor. I live at 236 Bacon Street in Boston. And at the bottom of the letter it said, "Do you know your Boston address is 236? So I knew I had a patient that I still had a relationship with. But interestingly, what I was able to do was to call the laboratory. And here's what happened when the patient returned and showed me his equal package, and this is what was in the package. But in one day, a new provisional was milled, and the patient was able to leave the next day with a provisional. So I did something that was retrievable. It was repeatable. It had an enormous impact on our workflow because we didn't have to start over. So this was a fantastic benefit. But I decided that I wanted to understand why it was breaking. And the synaptic abutments were really small and circular. And so I felt that maybe we needed abutments that had more anatomical form to them. So what we did was manufactured in parallel. We took an impression on an implant level, and we simultaneously designed abutments, core file, provisional, to have a provisional that you can see on the right-hand side that was accommodated and supported by patient-specific abutments. So interestingly, and this was, in this case, we had them perfectly parallel because they're designed on computer, they're designed to be parallel, and they're manufactured to a certain standard with more anatomical form. So the materials were not as thin as they might have been because of the small synaptic abutments. So we had less thickness of material, but we had better support. So we had delivered to us a provisional and something we call a prototype. I take the prototype, I can try this in the patient's mouth, I can make adjustments in it, and we can take this, send it back to the laboratory, and it becomes a form that the laboratory will then copy mill or just CAD/CAM, and we can go literally right to the final restoration. So this prototype can be clear, it can be opaque, it could be in polymethyl methacrylate. So here we have the patient-specific abutments in the mouth and the provisional that were delivered at one time, and the time was compressed tremendously by leveraging these technologies in the value chain and being able to manufacture all of this work at one time. So another patient, another example. Patient presents to us having had immediate placement and loading, immediate implants and loading with extractions, and she is in an enormous amount of pain and in a compromised psychological state. So first thing I did was remove the temporary, and you can see here's what we saw. Some temporary abutments still in the patient's mouth, one of the patient's temporary abutment in the provisional. We knew we had to do something really rapidly because the patient's psychological state was really compromised. So we leveraged technology to do something as quickly as possible. We did this first by making an implant level impression, by following complete denture techniques and concepts to design for aesthetics and function. And we would restore the lower arch at a later date. And then we manufactured in parallel provisionals and patient-specific abutments. And what you're looking at here are patient-specific abutments that are parallel. They've been designed on a computer and manufactured on a computer. And this is just about 5 minutes after we place the abutments. Immediately already you're seeing soft tissue that is improving. And then this was the provisional that we delivered. So we took something, we leveraged technology, and among the things that have impacted us tremendously is that the patient-specific abutment, for instance, took 2 or 3 weeks some time ago. to manufacture. Today it can be done in literally overnight or in 2 days. And with the digital design and manufacturing of a prosthesis, that also can be done in a couple of days. So we're able to take a custom abutment, a core file, manufacture together, and do a prosthesis literally in a matter of a couple of days as a routine. So we've gone from this compromised state to this state where we've captured the patient's oral health and mental health. So I want to show you another extension of taking technologies and merging them over the value chain. So here's an edentulous patient. She's been wearing a complete denture for 25 years. On the right-hand screen, actually, you can see what she looks like with her denture in place. And we made new denture for her. And basically what we do with all of these patients when they're in a compromised state that you just saw, we make a new denture for a patient because you need that to be able to plan where the implants are placed. We use these duplicate dentures as a radiographic template, as a surgical guide, as a custom impression tray, as a record base, as a guide for the final restoration. You'll see tremendous value here in the replication of the complete denture. In this case, it's BioCryl X. It's a radiopaque translucent resin. And so here you can see we've taken the duplicate of the patient's new denture, and we're able to merge it with the CBCT. Actually, it was worn by the patient at the time of the CBCT, and we're able to identify implant location, restorative space. One of the values of this kind of technology also is something where we can create masks. With the Simplant software, we're able to divide things so that we can see the teeth, the bone, the implants, the denture base. We can turn them on and off so that we can see different aspects of the way the patient would look so that we can have a better understanding of our final restoration. And so you're seeing the placement plan for the implants, and you're seeing the 4 implants in place. So what you're seeing now is a duplicate of the denture. We modified it to be an open tray impression tray. So we're capturing the implant placement to the patient's actual denture. And this becomes a tremendous value to us. We're also taking this denture, duplicate denture, and we'll use it as an occlusive record. And we'll also use it as a reference point for the final design of the implants. So the denture is scanned, the model is scanned, and we have manufactured actually patient-specific abutments, which are tapered, cone-shaped abutments to create a fixed, removable, friction-fit, complete denture. These are called conus abutments. They're perfectly parallel. This is a system that is similar to something unique to the ankylosing system, which has been done for years in Europe, something called the Syncone system. And that was making cones that were 4, 5, and 6 degree tapers with stock abutments, place them, and do something retrofitting to a complete denture that you're about to see here. But what technology has done is it's taken this concept of the stock abutment and this friction fit, and it's taken it to a different level by having elevated the standard of design to make them perfectly parallel because it's on a computer, and then they're manufactured to a certain standard. So these are conus abutments, and then there are gold copings that have a very tight friction fit that are engaged or incorporated into the complete denture. So here you're seeing the cone, a silicone blockout ring, and then the friction coping. And here you can see the denture is in place, and critical here with picking up any kind of attachment, as well as in this case, that the denture has to be able to seat in occlusion and not touch any of the hardware. We don't want anything to be displaced even slightly. And then we're doing a direct pickup. This could be an indirect pickup done in the laboratory. In this case, we did a direct pickup with denture colored pink autopolymerizing resin. There are many different materials to do this, many different techniques. And we were able to capture the copings and then did some finishing. And you can see this is how the patient, how we completed this friction fit denture. Okay, here it is with the new denture that is now incorporated into with the copings. And interestingly, often when we do these types of cases, we do them with frameworks. In this case, the patient we felt that the physical form of the patient, that we could do this without doing the framework. And she has had this prosthesis for 3 years and there's been no breakage. Her only complaint is that it's difficult to remove, which is probably the one complaint that I would like to hear. So we have different ways to facilitate the patient's removal of it. Also, we were going to cut back the flange and make it palateless, but the patient said, I've had a palate for 25 years. I don't want that removed. So we retained that at the request of the patient. So as you look at this value chain, the one thing that you often see that's missing is a link for communication. And in our practice, we use something called translab data entry. And basically what this is a service which helps us to manage our laboratory work with guided data entry, collaboration, and secure line. So I appreciate the opportunity to be here today. This is my email. I would encourage you, if you have any questions, feel free to email me. And thank you, Dental XP, and thank you, Dentsply.